Hi, I'm Dr. Michael Blaha here with Cardiosource.com here in Washington, D.C. at the Scientific Sessions. And I'm here with Dr. Paul Muntner, Professor of Epidemiology at the University of Alabama, Birmingham, to talk about his recent outstanding study presented here at the Scientific Sessions and reported in JAMA this week, looking at a validation exercise of the new pooled CVD risk calculator in his cohort, the REGARDS cohort. So first of all, welcome, Paul.
Thank you very much for the introduction.
Yeah, and I wanted to talk about, first of all, tell the viewers a little bit about the REGARDS study.
Okay, I'd be delighted to. So the REGARDS stands for Reasons for the Geographic and Racial Differences in Stroke. And the REGARDS study is funded by the National Institutes of Health. It was initiated in 2003 when we started to investigate why blacks have higher rates of stroke compared to whites, and why strokes occur more frequently in the southeastern United States versus other regions of the country. And since that time, participants have, I guess at baseline, participants had a study visit in their house, and they've been followed since through, the data we use is through 2010. And one of the very innovative things about REGARDS is it does include participants from all 48 states in the continental US, and so it has broad generalizability.
Right, that's great. So, you know, it's been a hot topic recently about the performance of the new risk calculator, and we talk about discrimination of events, whether the risk calculator can figure out who is and isn't going to have an event, but also calibration. Is the risk score giving a risk estimate that's accurate, an absolute risk estimate compared to what we see? Now, summarize your results for us.
So I'd be delighted to. So overall, what we saw, we first started off with people without a history of cardiovascular disease. And we saw, similar to what has been reported in the past, that the risk prediction equations did appear to overestimate risk, meaning the calibration was poor. However, once we took out individuals already taking statins and individuals already with a clinical indication for a statin, for example, those with diabetes, we found that the equations worked quite well in that the risk predicted by the equations was similar to what we observed during the follow-up of participants.
Right, and if I understand right, you've looked at that population because that's where the guidelines say to use this new risk calculator in patients whom the decision for, let's say, statins is unclear.
Exactly. When we started to do this work, we thought about how we can make this most clinically relevant, and we felt that to do so, it would make sense to focus on people where a treatment decision could possibly be made based on their estimated risk for having a CVD event.
So this makes sense, and I think that the viewers are all going to want to know. So we've heard about this brief report in The Lancet that looked at a couple other cohorts that saw poor calibration in the sense of overestimation of risk. And here, I think we're seeing, once you take into account the analyses that you've talked about, a better calibration. So compare and contrast what we see in REGARDS versus what's been reported in the limited reports from these other cohorts.
Okay. So the other cohorts did a good job. I don't want to criticize the work they did. However, I think one of the important parts of our paper was including the individuals taking statins and seeing that we got similar to results to what had been reported. And so I think it provides a nice way to look at why we're seeing better calibration. Obviously, who's going to get treated with a statin is a higher risk individual. And so therefore, that's why you may be seeing this overestimation of risk in the prior studies, is that they included people taking statins which lowered their risk for having a future event.
So one of the take-homes, I think, from your analysis was that statin use might be part or maybe one of the main explanatory factors for why we see overestimation in other cohorts. Is that right?
Right. So I think that statin use is, I think, one of the two major reasons, and we can come back to the second one in a second. It's one of the two major reasons why we're seeing this overestimation. And even in cohorts where they may take out people starting statins at baseline, people do start statins during follow-up. We didn't include these data in our paper, but we saw a graded association between higher predicted risk and higher initiation of statins post-baseline, where within 5 years of the REGARDS baseline, about 40% of people with a 10-year predicted risk above 10% were on a statin.
Initiated on a statin.
Yeah,
and we talked about this a little bit, and I think this is important for everyone to kind of think about and understand where we're headed. But another thing you did in your paper is you also augmented the outcomes in REGARDS with Medicare claims files, looking for events that might have been missed in the routine follow-up of regards. Can you talk a little bit about that and some of the implications for epidemiology studies in general?
Okay. So what we did in our analysis, we know the cohorts that were used to derive the pooled cohort risk equations were done in an era where they're able to have active surveillance, meaning that, for example, in the ERIC study, staff went to local hospitals and reviewed discharge summaries to identify participants having events. However, in regards being this broad, large, simple epidemiology study, we were unable to do that. So we had a sense, based on some other data we'd seen from other studies, that we were missing some events.
Right.
So we linked regards participants to Medicare enrollment files, and we looked for, using validated algorithms, we looked for myocardial infarctions and stroke events that appeared to be missed through the study adjudication process.
Yeah, and that could be probably your other explanatory factor for why you might have seen overprediction in other studies. That gap closes when you add those extra events that Medicare picked up.
Right, and it wasn't something that we just thought of on our own.
Right.
There was a paper published in December in Circulation Quality Care and Outcomes from the Women's Health Initiative, where they found that Medicare, they identified 29% extra additional myocardial infarctions in Medicare that were not detected through trial follow-up.
So I guess let's talk about implications real quick, because everyone's going to want to know this new risk calculator. Should we use it? Should we not use it? Where do we stand right now, do you think, with the risk calculator? And what more needs to be done? And what questions do you think have been answered?
Well, I think that any new risk prediction tool needs to be externally validated. And I'd like to think we did a good job in regards, but it'd be good to see this done in a couple of other cohorts that have done a careful analysis, thinking about these issues related to initiation of statin, picking up events through surveillance.
Right.
And I think that would be helpful. However, I think in a general population sample of people who aren't very high risk, those without diabetes, the equation does work fairly well, that it possibly could be used while these future studies are being conducted.
Makes sense. Maybe one quick more question. Should we be using these active surveillance techniques in other studies, like clinical trials, where maybe events could be missed?
So the way, for a little primer, is the way these large epidemiology studies work, as well as most large clinical trials, is there's a trigger to go after a potential myocardial infarction or stroke event, where it starts with a participant reporting that they had an event, or a proxy reporting.
Right, and they go look for.
Right, and in the Women's Health Initiative, they identified the reasons why they're not picking up these events that are seen in claims, and it's because a participant didn't report it. So there could be this self-report or recall issue, and the other reason is in this era of HIPAA, sometimes hospitals are unwilling to release a chart such that an event can be adjudicated.
Right.
However, in the Women's Health Initiative also, they reran their analyses using Medicare events, and they had very similar results, providing confidence that their primary results are valid. What is biased is the absolute risk level that they detect.
Right. Well, interesting implications for studies in general, and I think we've learned a little bit about the risk calculator, and we'll look forward to more studies in this area, but Dr. Muntner's study is a really important one. I recommend you go to JAMA and read it, and I hope you enjoyed this discussion today. Thank you.